Hello, everyone. My name is Dennis Yang. I'm an associate professor of medicine and the director of the Advanced Endoscopy Fellowship Program here at the University of Florida. On behalf of me and my co-authors, I want to thank the editors of Gastrointestinal Endoscopy and the viewers for the opportunity to discuss our study titled Evaluating Learning Curves and Competence in Colorectal EMR among Advanced Endoscopy Fellows, a pilot multi-center prospective trial using cumulative sum analysis. As we all know, colorectal EMR is an effective first-line treatment strategy for the removal of most colorectal polyps. Yet, colorectal EMR is a complex endoscopic resection technique, and outcomes are highly operator-dependent. Surprisingly, formal data on colorectal EMR training are lacking, despite its wide use in clinical practice. Hence, the primary aim of our study was to evaluate learning curves and competence in colorectal EMR training among advanced endoscopy fellows using a novel standardized assessment tool. This pilot study was designed as a multi-center prospective study that included 6 advanced endoscopy fellows from 6 different advanced endoscopy programs. The aim of the study, again, was to evaluate the performance in colorectal EMR during their advanced endoscopy fellowship training. In order to do so, we developed a novel comprehensive EMR standardized assessment tool designed by both consensus opinion and review of the literature by EMR experts in accordance to recent recommendations by the U.S. Multitask Force. The aim of the tool was to evaluate both key cognitive and technical skills for the performance of high-quality colorectal EMR, including such items such as adequate lesion assessment, recognition of submucosal invasive disease when present, identification, categorization, of adverse events. Technical skills included position and stabilization of the endoscope, submucosal lifting, endoscopic snare resection, adjunct techniques for endoscopic resection, management of adverse events, and an elective closure when indicated. A 4-point scoring system was developed to grade each one of these core skills. And for purpose of our studies, trainees were able to achieve the task without any assistance received a score of a 4, whereas those who required minimal verbal cues got a 3. Trainees received a 2 if they required multiple verbal cues or actual hands-on assistance to complete the task, and only 1 point if they were unable to complete the skill. In addition to grading each individual skill, a 10-point scoring system was used to assign a general assessment grade as shown here. Cumulative sum analysis was utilized to evaluate the learning curves and competence thresholds. For the purposes of the study, a grade of 3 or more for individual skills and a grade of 7 or more for the general assessment was considered a procedural success, which was defined as minimal numeric score for competence. Decision limits or thresholds corresponding to acceptable and unacceptable failure rates were pre-specified at 10 and 20% respectively. This figure is a graphical representation of how cumulative sum analysis is applied to evaluate learning curves and competence thresholds. If the QUESTION curve crosses the upper decision limit from below, which corresponds to the red arrow as you see in this figure, the failure rates have reached the preset unacceptable rates, indicating the need for further training. Conversely, competence is defined when the curve crosses the lower decision limit from above, as shown by the green line in this figure. If the QSUM curve remains between the 2 decision limits, as demonstrated by the yellow line, then ongoing observation is required during training. Overall, a total of 189 colorectal EMRs were performed by the 6 advanced fellows during the study period, with a mean of 31.5 procedures per study site trainee. The mean polyp size was approximately 2.4 centimeters, with a mean procedural time just a little bit over 20 minutes. There were no immediate post-procedural adverse events reported. This slide summarizes the learning curve and competence QSUM scores for some of the core cognitive and technical skills during training. As we previously discussed, competence is achieved when the QSUM curve crosses the competence threshold line from above. As you may be able to appreciate, only 2 out of 6 trainees, or 33%, crossed the competence threshold in terms of scope positioning, submucosal lifting, and endoscopic mucosal resection. Only half, or 3 out of 6, of these trainees crossed the acceptable performance threshold in terms of lesion assessment. Similarly, only 2 out of the 6 trainees crossed the competence threshold in terms of their overall assessment. The 2 trainees who achieved competence crossed this threshold after performing a total of 25 colorectal EMRs during training. The trainees were then asked to complete a self-assessment following their EMR fellowship. In the contrary to the data that I just previously showed, all trainees strongly or tended to agree feeling comfortable performing all of the core skills of colorectal EMR. Importantly, all of them also indicated feeling comfortable doing these procedures independently by the completion of their training. So overall, there are several important take-home points from our pilot study. For one, this is the first study formally evaluating colorectal EMR training using a novel comprehensive standardized assessment tool. Data from our study demonstrated that a relatively low proportion of trainees achieved competence on key aspects of EMR training during their standard fellowship, and suggests that the relatively low number of procedures performed may be insufficient to achieve competence despite their self-reported readiness for independent practice. We believe that this preliminary data provides some insight into the current status of colorectal EMR training among advanced endoscopy fellows. Future multi-center prospective data involving more training centers are needed to generate generalizable and reproducible learning curves and competence benchmarks in colorectal EMR training that can subsequently be used for standardization of training and perhaps for credentialing purposes. Once again, we want to thank gastrointestinal endoscopy and encourage all the viewers to read our study for any additional information. Thank you very much.